Ear infections and vertigo.
So if you treat an ear infection with oral antibiotics in a patient with acute vertigo, what you're telling me is that the infection has eroded into temporal bone and is affecting the vestibular nerve. If that's the case, this is an emergency. You need to send that patient to hospital. Suppurative infections eroding into temporal bone causing acute vertigo is almost unheard of in the United Kingdom. In contrast, it's something that you see in the third world. So if you've got a patient with acute vertigo and you want to prescribe oral antibiotics, ask yourself, why am I doing this?
Vertebrobasilar insufficiency and cervicogenic causes of dizziness.
Okay, so vertebrobasilar insufficiency effectively does not exist. Those patients who get dizzy when they look up or bend down, they have benign paroxysmal positional vertigo. End of story. Cervicogenic dizziness. This is a very debatable diagnosis. I would suggest that the doctor making that diagnosis look for standard causes of dizziness. Almost always, when they look hard enough, they'll find another cause, like BPPV or vestibular migraine. Those are definitely treatable. I am not aware of treatments for cervicogenic dizziness. I have to say that, bear in mind that many patients with forms of vestibular migraine complain of occipital and or neck pain, and there is a lot of muscle spasm in association with migraine, and certainly modulating areas of the back of the head and massage and even cranial massage can modulate migrainous features and allow patients to feel better. So because these procedures are not deleterious to one's ill health and patients receive some benefit, then there's no harm in going down that fashion at all. I'm definitely in favor of approaches that cause no harm and improve symptoms. But beware that the physiology behind cervicogenic dizziness is somewhat lacking.
Recurrent labyrinthitis.
So recurrent labyrinthitis does not exist. Labyrinthitis typically is a one-off event. You can have dizziness after labyrinthitis or vestibular neuritis, and the causes are post-labyrinthitis benign paroxysmal positional vertigo, which in another video will show you how to diagnose and treat with a very good response. Patients can have migraine. It could be that the first episode, which was diagnosed as labyrinthitis or vestibular neuritis, was not that, but in fact first presentation of vestibular migraine. So you have to reappraise your diagnosis. Certainly in the balanced dizziness clinic that I run, I don't always get it right, and I reappraise the diagnosis that I made the first time. One always has to keep an open mind, so you have to reappraise that diagnosis. Then, of course, if you did have an initial problem with vestibular neuritis or labyrinthitis, the patient gets dizziness again, it might be because of a maladaptive response. They are because the approach to treating the patient acutely maybe involved not enough mobility, poor mobilizing, or maybe excessive vestibular sedatives. So it doesn't exist, but look for things that we can treat.